We're first going to bring up Dr. Christine Bishop, and she's going to speak on behalf of the Bishop family.
My brother David and my sister Ellen and I are just so pleased that this Bishop lecture has been started and has gone on for now the 7th iteration. We love coming home to Ann Arbor once in a while, and this has really been wonderful for us. When the lecture was established, the first thought I had was, we've got to have Norman Daniels come and speak. And the reason for that is that in 1981, my father got in touch with me. He was getting ever more interested in ethical issues. And he told me about a National Endowment for the Humanities seminar that was being run for academics at Tufts University, run by Norman Daniels, who was going to present or work with them on the work of John Rawls. And this wasn't my father's favorite way to get into philosophy and ethics, but the location was perfect because he could come, my mother and father could come and spend 4 weeks at our house with their grandchildren and with me and so on. Well, of course, he was actually very interested in these issues. I'm an economist. I've always been interested in the distribution of resources in healthcare. I worked on healthcare for all my career, and particularly care for older adults and so on, and people with disabilities. But my dad also, from an early time, was not only interested in the very important issues that physicians work with every day in terms of dealing with clinical ethical problems in the wonderful and one-to-one relationships that you have with your patients, but also on the distribution over populations of how we should be conducting healthcare. And if someone catches me later, I can tell you the story of how he led a medical honor society meeting at our house, and it must have been in the 50s. I crept down the stairs with Wilbur Cohen, who was here at that time, about so-called socialized medicine, which was a very shocking idea. In any event, we did go to this. Well, I applied to the seminar too, and my boss at the time said, "Oh, that's a great thing for you to do." I was doing research at Brandeis, and so I went too, and we combined with a dozen people who were teaching in nursing and medical schools, and had a really fantastic 4 weeks experience with Norman. And it was a very the group cohered so much that we actually met the next summer in Chicago and explored the issues that Norman was working on at that time. And so it is just a great pleasure for me. It was a pleasure for me to be in a seminar with my dad as a young person, and now to hear Norman speak. But I think he's going to get a full introduction. That was a full introduction from our family.
I'm sorry, but I was not about to give up the privilege of introducing, as I said to someone yesterday, my hero in bioethics. So I have been a longtime follower of Norm Daniels. In fact, what Christine didn't tell you was that she's actually acknowledged in his book, Just Healthcare. And this very book was given to me by Mark Young, another member of the Bishop family, when I was a medical student. And when I expressed an interest in ethics and cost containment, he gave me this, and we worked together on some things. And I've been doing it ever since, and the problem's still not solved. So what's the deal? But anyway, Norm Daniels' work has been an inspiration to me for a long time. This is not the only book of his that I have, and I probably have more too. These are just the justice ones. So he's written many, many books. He's Mary B. Saltonstall, Professor of Population Ethics and Professor of Ethics and Population Health at Harvard, the Michigan of the East. And has published lots of stuff. He's been involved nationally and internationally in a really underworked area of justice, fairness in healthcare, and priority setting. And he's been an inspiration to lots of people I know nationally and internationally in those areas in so many ways, in public health, global health, rationing and priority setting, and he's one of the leaders in the field. If not the, you and Dan Callahan are really the two sort of folks people think about when they think about justice and bioethics. And I'm delighted to introduce you and look forward to hearing, as always, what you have to say.
Thanks. It's an honor to be here, and I wanted to thank Christine and David and Ellen. I remember well the 1981. I didn't remember the year, but it was one of the first NEH seminars that I conducted, and that institution is now on the chopping block according to the budgets that President Trump I will say a lot about the proposals. I've known Susan for a long time, and a great honor to be here as well. For your invitation, I see Susan and her work with Marion and on the chat program as one of the important contributions to priority setting in the world. So thank you. Is it the side? Okay. So what I wanted to talk about today is the attack on the ACA and the attempt to provide us with another model for thinking about the state role in providing access to insurance. So this talk is based on work that I've done with primarily with Brendan Saloner, who is at Johns Hopkins now, and to a lesser extent with Adrian Gelpi, who is at the University of Miami. And these are both former students of mine, came out of the program in health policy that Joe Newhouse started, and I direct the ethics concentrate, or did direct the ethics concentration of that. Let me go on. I wanted to introduce you to the fair equality of opportunity. That's what FEO stands for. Argument for universal coverage, and suggest that the ACA represents universal coverage approach or model. However far it falls short of delivering on universal coverage. And the AHCA, which was the plan that was removed from consideration by the Republican leadership and by the Trump administration, represents the emphasis on choice and not coverage, and it's called universal access as an approach. So what I want to suggest are, come back to the ACA if I have time at the end, and talk a little bit about some of the other issues that you might raise about the ACA as inadequate plan, and this is based on earlier work that I did with Brendan and Adrian on the ACA. So I wanted to talk a little bit about the policy context in which all of this takes place. So universal coverage aims to provide every individual with a comprehensive health insurance in high-income countries. And if you go down to the last bullet on this, it is now a WHO goal to provide, but there is a lot of concern about the thinness of the benefit packages in many of the countries that claim to have universal coverage. So I was part of a group that developed a ethical guidance to the WHO on how to look at the expansion of the thinness of that package in 3 dimensions. So I wanted to say a little bit about the fair equality of opportunity account and the access to insurance approach that it supports. So in general, people who have insurance are healthier as a result of having the insurance. And I could give you a lot of citations to that result, but a lot of the Institute of Medicine reports that came out, including the unequal treatment reports, showed that there was a positive effect of having insurance. So the fundamental intuition that I wanted to build on was that disease and disability are reduced by healthcare, and that we have an obligation as a society to promote health in a population through a commitment that is widespread, that many people have to fair equality of opportunity. And by fair equality of opportunity, I'm imagining that I'm using a phrase that comes out of John Rawls, as opposed to what might be referred to as formal equality of opportunity. The idea that we are simply bringing certain skills and talents to the market, and we have to worry a little bit about how they developed and what context they developed in. And the fair equality of opportunity means that the institutions for developing those talents and skills have to be fair to the people who go through them as well. So the idea is that if you were concerned with fair equality of opportunity, you'd be concerned about the design of those institutions as protecting the development of the talents and skills of the population, as well as what you would do in recognizing that it's those talents and skills that are the basis for judging the merits of people to have certain positions in society. So the argument is that education is very important. And the Affordable Care Act, which is at this point still the law of the land, arguably has as a universal coverage as a goal. whereas it's to be contrasted with the AHCA, which has the opportunity to buy insurance if you want it as a goal. And I will talk a little bit about the contrast between those views. But even if you look at the policy underlying the estimates that were given of coverage under the ACA, at the time it was passed, 32 million was the maximum. And since then, there was not only the exclusion of the unauthorized immigrants, but the Medicaid decision by the Roberts Court, Supreme Court, that basically said you don't have to go along with the bribes that the administration was giving to expand Medicaid the way Michigan did. But you could cut into the 32 million that was estimated as the best case scenario for the ACA in terms of reaching universal coverage. I point out that of the 32 million out of 47 million at the time the health care plan was passed is a major reduction promised, not delivered on fully. But it was a goal of the plan. And I think a lot of the goal has been achieved, so that there is a lot of the reduction in coverage, the coverage gap that we find in society. And if you go back to the estimates I gave from the, or the citation I gave to the Institute of Medicine reports, you can see that people are probably healthier as a result of having the access to that insurance or the coverage that required. So in the current political context, universal access is likely a way of shifting the terms of the debate to conceal, I think, the fact that many people are going to lose health insurance and won't receive any replacement, even a very limited one that's adequate to the coverage. So in preparation for this policy proposal, the AHCA, the House debated and withdrew the AHCA bill, but we are now facing ongoing efforts to weaken the ACA and threats to the ACA. So I will talk a little bit about that. So one way to grasp how substantially the current move to universal access deviates from universal coverage is to compare how many people would be covered and at what cost. So I've given you a couple of citations here. All the analysis of the prior work of the Republican Party in reducing in the loss of coverage through their proposals focuses on the not the AHCA, because this predates the development of that plan, but the prior plans were all judged to be not have coverage as the goal. And when the AHCA was finally analyzed by the Congressional Budget Office, it was argued that millions of people would lose their coverage even very quickly in the following year compared to the current plans, which have not been fully implemented at the state level of Medicaid. So you could argue that if the subsidies under the ACA are inadequate, then the Republican plans will be even worse. So the subsidies would be reduced even further. And the Freedom Caucus, as I understand it, was the main opposition to having any kinds of subsidies supported. And their fight was focused on reducing the entitlements to care that would come from having those subsidies in the package. So what I'm going to suggest is that the millions of people who would lose coverage suggests that the AHCA doesn't achieve the purported goal of providing universal access to health care. And if not, if it doesn't, then you could ask the question, what resources would be required to achieve universal access on the terms that were plausibly argued by the Republican leadership? And you could also ask, and this is the task of the remarks that I'll make, whether there's any normative basis for preferring universal access to universal coverage, and that's what I want to talk about. So what I have on the slide in front of you is a quote from Paul Ryan, our Speaker of the House, saying, "It's not our job to make people do something that they don't want to do. It's our job to have a system where people can get universal access to affordable coverage if they choose to do so or not." That's what we're going to be accomplishing. And what I've suggested is that they're not accomplishing that with the AHCA. And I'm going to argue with regard to alternatives that might be pursued. So you could ask, when do we have real choice about buying a health plan? And the key consideration I want to focus on is under what circumstances an individual should be deemed as reasonably able to obtain coverage if the individual has a real choice to make, which is what I was quoting Ryan as promising. And I want to suggest that in the 4 bullets that follow, that potential tests. So you could compare the cost of coverage relative to an individual's resources. What do you actually have to spend on health care? You might ask, what is the actuarial value of the benefit package that's being provided? How much of the total expected cost of the health care that somebody might need is to be paid out of pocket as an overlay on top of the premiums? You could ask what happened to the essential health benefits that are in the package. There were 10 categories of care that were part of the ACA, and they were called the essential health benefits. From what I've read in the New York Times and other papers that I read, is that although the essential benefits were not cut from the AHCA, they are cut from current proposals that are being talked about. And that, I think, is by the support of the Freedom Caucus. So you could ask some questions about the availability and proximity of care as a further test of whether you have a real choice. So can you go to find an adequate network of providers that accept your insurance where you live? And I think each of these issues is raised in the context of the ACA. So if universal access is achieved, and if the only plan acceptable to someone is a high deductible plan with a narrow network of providers, then you could ask the question, is the purchasing of that plan, does it require people to give up what they need to spend their limited resources on? So I'm focusing this question on low-income individuals and asking whether they have the resources to buy a healthcare benefit that would cut into their budget for daily necessities or not. And if the answer is no, then we may require levels of subsidization, I think, that approach the level of resources required to achieve universal coverage. And that is what I suggested the ACA. You could argue that the ACA subsidies are inadequate and fail to meet this test. But if they're inadequate, then the even smaller amounts that are included in the subsidies would be less than adequate, far less than adequate. The main advantage of the universal access program is that it provides less coercion. So I want to focus your attention on this as the goal of the universal access demand, that it's going to disavow any steps that coerce individuals. For example, the individual mandate that is was survived the Supreme Court decision about the sustainability of the ACA, despite the attack on the Medicaid expansion that was included in that decision. It did say that if the benefits were included as a tax benefit, then they were to be accepted as so the sanctions that were offered to people for refusing to get or not getting coverage for insurance were ones that the led to you'd pay them in the form of a penalty on your taxes, and that was considered a tax penalty. And I should argue that that's a form of coercion. So if you think that public option is acceptable, you're accepting a form of coercive inclusion of people, and you are deviating from what the universal access program says it's. But since the AHCA included some subsidies, maybe inadequate ones or far less than the ACA provided. It was accepting some forms of coercion, period. So, you could ask whether the universal access approach provides for less coercion. And I just wanted to highlight what this assumption assumes. It assumes that all coercion is bad. And I just gave you an example of how eyes were closed about some of the forms of coercion that were included in that, in the AHCA. Of course, if you strip away all those coercions, then you have even more loss of coverage. Because the ACA, I'm sorry, to confuse you with the reference, but the ACA, the current system does allow for some justifiable coercion. And I will talk a little bit about the forms of coercion that are acceptable. So let's go back to the increased choice that the universal access promises. Some people, the assumption is that some people maybe decide they would rather have something other than health care, and they choose to forego the coverage. So the assumption is that this is a morally permissible move to make. I'm going to argue that it harms people, that the withdrawal of that support for the health system from the purchase of insurance, and that it makes the harms to third parties greater than they. It harms third parties, the loss of that choice. But the counter argument is that this is morally permissible to refuse to buy insurance, so long as people are afforded an opportunity. So let's assume that the subsidies are adequate to buy, and I'm making a big assumption here about the funding levels. So I'm going to come back to what this means, but the argument is that, especially for people with limited incomes and some of the young, having access to health care may be a lower priority than meeting other consumption needs, for example. So I want to give more prominence to that view, which is, I think, at the heart of the universal access view, and suggest that if you were to increase subsidies and give people real choices, that they would have perhaps some increased choice. But that is not what anyone is being offered. So imagine a thought experiment to illustrate this point. What if the government provided everyone with a subsidy to purchase an actuarially fair, comprehensive insurance product, but people could elect to pocket the cash instead and either buy no insurance, or that's a form of pocketing the cash. You save your premiums. Or purchase only catastrophic health insurance plans. You buy an insurance plan that doesn't cover your real health needs, but if once you discover you're sick, and that's what the catastrophic and high deductible plans do. So the argument is that if you did this and you would have greater economic welfare because more people would get what they want in the world, and that's a gain for their satisfaction levels and their welfare levels, and you would have more choice. People could refuse in the absence of a mandate. So I want to emphasize the last bullet that I have up here, that this thought experiment goes beyond what anyone has offered in the AHCA, because that's a very important point. So what if you discover you're ill? So the proposed scheme allows people to essentially bargain away their access to the health care they may come to need, meaning that some people will end up much sicker, but presumably wealthier than they would be under a system of universal coverage. Should people be allowed to go uninsured if that means no health care when they need it? And I think a lot of the appeal of the AHCA was people were assuming they would get health care if they really needed it and could buy their way back into the system. If you did away with an EMTALA, the emergency medical care that people had access to, and wasn't being touched by itself, then maybe you would be removing an incentive to say, I'll go uninsured if I'm young, because I don't need the health care. Of course, I might get hit by a bus or have some sort of accident that, even a skiing accident that requires me to lay out of pocket for the injuries I have. And those are likely to be covered by the ACA under the essential benefits plans or coverage that it requires, but not by a catastrophic plan that you might buy instead if you bought anything, and certainly not by your free riding on the system. So I'm going to suggest that there's a kind of harm to third parties that comes from the increased choice we're allowing and the waiving of that goal. And the harm to third parties comes in several forms. It comes from free riding, which I'll talk about shortly, but also about the increase in the stratification of the health system when you do away with the community rating of health plans. So the idea is that you could market these plans, including high cost and high deductible plans, to people who have low risk, like people who are younger than your working age or late working age population, almost everyone in this room except some of the students. And that increased stratification of the risk pool, I would argue, is a harm to the individuals, but also to the society, which wants to market that insurance in a fair way to people. And I think it's unfair to ask people to pay more just because they're sicker and they use more. So I would argue that the harm to third party comes from the increased risk of adverse selection that you get. And there's a further harm that comes from allowing people who don't contribute to a system to free ride. And a lot of the choice that we allow people in that system of universal access raises the cost to third parties, raises the cost to everyone else, because they're going to have a system that is set up to receive people and give them care, whether they contributed to it or not. So the extra cost of a system that is set up in those ways constitutes a harm to society and to the individuals who are buying insurance and who need it. So I would argue that the AHCA created incentives to free ride, as long as it increased also the adverse selection in the society. And I wanted to emphasize this last point by talking a little bit about actuarial fairness and how it's not really fairness in healthcare. I think in the model for thinking about insurance is that you're buying some form of security, and that might make sense if you're buying fire insurance or home insurance that protects you against your house catching fire. If you have a wooden house rather than a brick house, it may be more expensive to protect you against those risks, because the cost of replacing a wooden house might be lower, but the frequency of a burn in a wooden house is higher than in a brick house. But healthcare is not like that. We might get any kind of condition, and so that's like having the fire, but it's in the form of disease. And we don't think that people who purchased a house or people have any choice in their choice of a disease. So my concern is that healthcare is really different from a lot of the other insurance schemes we have, and that we're not simply buying security from risks. We're buying healthcare, which we may also need, and shouldn't be distributed on the basis of how much it costs to get you that care. So the actuarial fairness is not a good model for health insurance, and yet it is the underlying claim about stratification in our system. So I want to suggest that on consequentialist grounds, the benefits to some don't outweigh the harms to others. That some people are being harmed, namely everybody who needs and buys insurance, and a few people will choose not to have health care, and they are a small number and the benefits to them taken one by one in a one-by-one comparison don't match the failure to have access to health care, which you would have through a comprehensive plan like the ACA. So let's talk a little bit about the individual mandate. Am I over time or? No, okay. So the claim against the individual mandate is that it tells us that we should buy insurance, and this is terrible. Because we're not told to buy, for example, shoes or broccoli or whatever your favorite example is. And this is rather odd that here's a mandate that tells you to buy a particular product. And we don't let the state tell us what to buy. So let's take shoes as an example, or broccoli, if you prefer. If an individual buys shoes, there is no effect on the free market that would be like people buying healthcare. It takes a group of people willing to pool their risks in order to have an insurance scheme. And nobody is pooling risks to have a market for shoes or broccoli. So I don't think we have to worry about the analogy between broccoli and shoes and healthcare insurance, because I don't think they are function in the same way. What do we say a little bit about the? This slide captures the disanalogy argument, providing an opportunity for others not to buy insurance for healthcare increases the stratification of the risk pool, but increasing stratification of the risk pool encourages adverse selection, and providing people with only the opportunity to buy healthcare insurance harms those who need it in two ways: through increased stratification and free riding, unlike a free market for broccoli. So I don't think there's an analogy between the broccoli argument and the health insurance market. Finally, I would argue that we don't have obligations to, we don't recognize obligations to make people better off in their welfare the way we do with their health care. In some of my writings, I've emphasized that the notion that there's a special moral importance to health care. And I don't want that argument to be distorted in these remarks, but I was referring in that context to the fact that many societies think they should distribute health care more equally than other goods, and that healthcare is different from some other goods. So a lot of societies that don't recognize income equality as an important goal would recognize health equity as an important goal, equality in health. So what accounts for that difference? That's what I was focusing on as the importance, special moral importance of healthcare. So I don't think that there is a widespread commitment to giving people equal money for some of the things that they may value more than healthcare. Suppose you value your chance of getting rich more than you value health care, and you want a world in which you could save the money from buying insurance. Do we have an obligation to give you the cash that we would have spent on your health care? My argument is no, we don't have that obligation, but we do have the obligation, social obligation, to provide the health care to people. That's what I meant by the special moral importance of health care. Some opponents would say this is only works under an ideal theory like Rawls's, and that if you don't have a redistribution of health, or rather of all income, then you don't have you might have some people missing the chance to buy important goods that they need as much as healthcare. So I'm trying to focus a little bit on the source of the low income for some people, not everyone. But the source of the low income would be thinning a safety net significantly. And what I am interested in is that a lot of the people who are advocates for thinning the safety net are the same people who are attacking the ACA. So my conclusion is that we shouldn't focus on healthcare alone. So let me summarize the arguments that I made so far. To be comparable and to promote a real choice, the replacement must be funded at a much higher level than its advocates propose. So the AHCA or any alternatives have to be funded very significantly. And let's cash that out in terms of subsidies to buy insurance. And that's all independent of the choice that it promotes to harm third parties. But it's not independent of my assumption about the cost of those choices. One of the costs of those choices are the subsidies. And if you're not paying for those subsidies, then you don't have a real choice. But let's, for the sake of argument, suppose that we have a real choice and we've matched the subsidies that people have. Then we still have the problem of stratification and the free riding. So there are several problems that arise in the form of harms to third parties. So my claim is that it increases the cost of health insurance for others because of the free riding that it encourages, and it risks not being sustainable because of adverse selection, and it confuses actuarial fairness with fairness in healthcare. And the choice it promotes for the poor involves an unacceptable trade-off. They're being asked to trade, they'll get more choice, but they give up access to insurance coverage when needed. So they may be dead, but they're going to have more choice at some point before dying, I suppose. So the second conclusion I have is that we'll encounter further appeals to universal access in a further round of attacks on the ACA, and we're already seeing signs of that. I think if we'll see some of those attacks take the form of regulations that ease essential benefit requirements, and the current plan, as I understand it, removes a lot of the content of the health plan and allows for very high deductible catastrophic insurance as your option. That's what if you're a poor person, you'll buy a cheap plan that doesn't cover your needs when you get sick. We've already seen threats to reduce the enforcement of the mandate to health care. And we've seen states have more leeway in the packages they offer poor adults. I think that's going to become an important component of the further attack on the ACA. So you're going to create more incentives for high deductible health care with or without health savings accounts. So I think a lot of patients won't be punished, as I said in the previous bullet, for enforcing the individual mandate. But they will be able to buy high deductible plans. And employers can be encouraged to reduce health insurance coverage by capping tax exclusions or by encouraging individuals to participate, pardon the double C, in high deductible plans. So I wanted to conclude by saying the ACA is not perfect. We already saw that it was, and I shouldn't be taking, the carry away message from this talk is not about the perfect nature of the ACA, because I don't think it is, and I think people would, so I've attacked the ACA in various ways. So I have a paper with another former student, not Brendan, but Karen Ledeen, that is on the exclusion of unauthorized immigrants. Who are, so I could refer you to that in a volume that my dear friend now dead, John Aris, and was one of the authors of a volume that contains this article. And the citation I can give you, as well as the slides, if anybody asks me, or I don't know whether they're available online to you. Are they? But they should be. So the 15 million shortfall, that was the best estimate at the time the ACA was planned, included 12 million people who were unauthorized immigrants. That's the single largest group of people who, and the rest is noise in the system, apparently. But the single largest group is the group of excluded unauthorized immigrants. A further problem with the ACA is that it entrenches care as we know it, which is 50% more expensive than the next leading system in the world, Norway or Sweden or the Swiss. If you take seriously the statistics, and it's with the drop in the oil prices, I don't know if Norway will retain its lead in as the second most expensive player in the world. But we're by far the first, by far, and bending that cost curve is an important goal. Reducing the costs and making insurance truly affordable for people. So I've been focusing on the importance of expanding benefits through subsidies so that people can buy into plans, but I haven't talked about in anything else about the reduction of the costs of care. But I think this is an important intervention and can be worked on. So the other thing that's left out of the ACA, which is focused on treatment, is the sources of health inequalities in the United States and in the world in general. So I would argue, coming from a school of public health, at least for another few months, that the inequalities that we see around us are the result of a lot of things beyond the medical care system. And they are maybe exacerbated by some behaviors in the medical care system, but they're not produced by them. And that's a very important finding from the social determinant literature, that you could have universal access as it exists in the British system, but it doesn't reduce health inequalities in that society at all, very significantly. And that's an important finding. So you might eliminate physician behavior and a lot of the clinical behaviors of people are an effort to get them to behave in ways that are not exclusionary. But that's only a small part of the inequalities we find in healthcare, in health status in the population. And that is beyond the scope of the insurance system. So I wanted to end on the note that I'm aware of that, and I wasn't arguing that the ACA was perfect. But I'm happy to take your questions. Yes.
Thank you, Professor Daniels. Great and really very timely talk. I really appreciated the overall view of the ethics and the issues. So if we eliminated community ratings so that everybody is not on an equal footing, what are your thoughts about the ethicalness and sufficiency of high-risk pools?
So you're asking me to set aside my concerns about people who are at higher risk paying more?
Well, I'd like to hear your thoughts on the gravity of that and whether high-risk pools can adjust for people's financial shortcomings.
Well, if the basis of the high-risk pool is that you pay more, and the AHCA allowed people to pay a lot more for, especially if they were older, for entrance into the high-risk pool and buying any plan on it. Suppose you were not poor, but in a high-risk pool, then you would pay the going rate. And my view is that that's not fair to people. And that's what I would argue. So I don't think the high-risk pools are a substitute for concerns about the fairness of a financing scheme.
In your experience, do high-risk pools usually require poor people to pay more to enter into those pools?
I wasn't talking just about poor people. Suppose you're if the going rate on access to insurance is much higher than it would be I've paid for years for family coverage because of my wife and son, and in an employer-based plan, but I was subsidized heavily by the universities that I've been in. So I didn't pay the full freight. but people who are buying into a high-risk pool are paying full freight. And that's what I'm concerned about. Yes.
Thank you very much. I always hear the story about when people get very sick and they don't have insurance, they go to the emergency room. So is that what you would consider a free rider? Could you speak about that a little bit?
Well, a lot of people don't have access to insurance because, and they go to the emergency room because it's available. But I don't think of people who can't afford insurance, any insurance, and are not sold any insurance as free riders. I'm thinking of a free rider as somebody who is taking advantage of a system but could afford to pay for it, but doesn't.
It seems like one of the major philosophical differences that you talked about between ACA and AHCA is that in ACA, because of community rating and because of the subsidies, you have the younger and healthier subsidizing the older and the sick, and AHCA took a lot of steps to eliminate that. When we think about Social Security and even Medicaid, we really think about an individual paying into a system to subsidize themselves in the future. Why can't we think of health insurance the same way, where we are paying into a system where we're young and healthy so that it subsidizes ourselves when we're older and sick? Is it just because it's a new system and the people haven't paid in previously, or is there something fundamentally different about it?
No, I think so suppose you have somebody who is older or younger in the British system, and it's a healthcare system over their whole lives. They understand that their tax revenues are based on their earnings. But what they get may be actuarially unfair when they're young, but actuarially more than fair when they're old. Our system artificially divides that into insurance and Medicare, employer-based insurance and Medicare. And I think that confuses people about the importance of thinking of a lifetime perspective on whether you have that insurance.
I wonder if you could comment on the ethical and political debate within the Republican Party on the issues you raised, because if we think back to the roots of the Affordable Care Act, it actually had its origins in George Bush Sr.'s plans and in the Heritage Foundation proposals in the early 90s that then Mitt Romney adopted in Massachusetts in 2005 and 2006, and then became the framework for the Affordable Care Act, but without any Republican support by the time President Obama and the Democrats approved it in 2010. And now it seems like the debate around universal coverage versus universal access is between the moderately conservative Republicans and the very conservative Republicans, because most Democrats have accepted through the arguments that you made for universal coverage. So how does this play out, and what parts of your argument do you think might be most influential for Republican legislators in Congress, in state government, for the case that you've made today?
There are two parts to your question. I certainly think what you're seeing is this Republican Party and the population as a whole moving to the right over the course of several decades. And that a position that was accepted and by both parties, since the Massachusetts health plan, which became the model for the ACA under Romney, was a bipartisan plan. I was on the healthcare task force under Clinton, and I can say that an informal survey of that plan that I did showed about 2/3 of the participants in the Healthcare Task Force, as it was called, were in favor of a plan that was never put on the agenda, the single-payer plan. I have a colleague at Harvard, Bill Shao, who worked with the Vermont legislature and governor to adopt a single-payer plan in Vermont, and that was shelved because of state funding issues. So my view is that the country has moved a long way away from that, and the Republican Party has engineered a lot of that move. So I don't see that as contradicting what I say. I just see it as a symptom of what I say.
So, Norm, I think you spoke quite a bit about sort of the adverse selection and free riding and how that harms others if there's no mandate to buy insurance like we have with auto insurance, for instance, or something like that. But let's assume that expanded coverage leads to less uncompensated care at, say, the hospital and emergency department level. Is that definitely going to lower costs for other people in the form of lower premiums? I think we can say, well, maybe a little. Clearly somebody's benefiting, but it's always important to ask who is being harmed in the case of cost shifting and free riders, or who is benefiting when you have expanded coverage and therefore less.
Who pays for the
uncompensated
care that you would get in public service hospitals? Or so yeah, so a lot of the so-called free care is not free. It's paid for through taxes, through the tax systems. And if you add that to what people are buying for insurance, with insurance, then you have a total amount which is much larger. So my view is that a lot of people who are excluded from comprehensive coverage and with continuity of care and so on have to go to very inefficient public systems that treat them on episodically as they show up for, and as many of you who have served in such hospitals know, it's not the best care that you could give a population. So people are getting worse care in those because they lack the continuity of care and lack access to preventive services. And they're much more likely to be a burden again on society when they come back than people who have access to regular care. So I don't think the example contradicts what I was saying. I think it's an example of the increased harms to third parties that come from having a system that is paid for invisibly through extra costs that are paid in taxes and don't show up in your premium. Any other questions? Yes.
So even though our country has moved away from the single-payer option, as you mentioned, I was wondering if you could speak to any ethical trade-offs that might exist with the single-payer system.
Yeah. First of all, a single-payer system is likely to be much less expensive, period, than a multiple-payer system. And that is because if you have a single payer, you have greater control over that budget that's spent on healthcare. But with that greater control comes reliance on the public pocket to pay for that. So maybe that's a trade-off if you think that the public will be stingy, and it has been in a lot of cases. So to take one example, long-term care, which is not provided in a lot of systems, including universal coverage systems, because it's not seen as medical. It's seen as social support for the elderly. I think a lot of that contrast is confused, and that we have an obligation, a social obligation to provide for that care. If you look at the public systems in a lot of countries that provide universal coverage, a lot of them don't provide all the care that you would get as the best off of Americans would get. But the best off of Americans are not the average American. So the trade-offs that I see are largely the ones that the best off Americans would be willing to pay for. So I don't, if you're asking me a question about what's fair to individuals, I don't think that's fair. If you're asking me a question about what will happen, that will happen.
Excuse me. Can you comment a bit about the paper that you wrote on exclusion of unauthorized immigrants? You mentioned that you'd be willing to share the slides with us, but because we have a little bit of time, could you share with us what you learned there?
Unauthorized immigrants are excluded from any benefits by the PRWORA. That's a mouthful of an acronym, but it's the personal responsibility law that was passed in 1996. I think, or 5 or something like that, a little over 20 years ago, under Clinton. And officially entrenched the difference between unauthorized and authorized legal immigrants, which hadn't been recognized in any American laws prior to that date. What that paper focuses on is that there are 2 reasons for inclusion. One is that a reciprocity argument, that many of the people who are unauthorized immigrants pay taxes and contribute to the health system. And it's surprising to a lot of the public what a proportion that is. It turns out you can't get a job in the US very likely if you don't have Social Security numbers. So people have phony Social Security numbers. So they pay a lot of taxes that they never collect on. And they're not eligible for any of the benefits under this law. The second argument is that members, and this goes to the issue of citizenship. So the argument is that many of the unauthorized immigrants are members of a community by any sociological standard that we could adopt. They are members of the community because they belong to civic groups, they own houses, they rent apartments, they contribute taxes, and so on. By any measure, they are members of the community. Does our social concern about protecting equality of opportunity for people focus only on people who are born here or who naturalize and become citizens, or is it all members of the community? And I think it's all members of the community. That's what Karen and I are arguing.
Thank you for your presentation. I'm wondering if you have any opinions about some of the loopholes or some of the religious exemptions that were granted in the ACA for religious groups who wanted to pool insurance because they had some moral objections to some kinds of healthcare that they didn't want to have to provide members of their group, or what happened in Hobby Lobby. But so there is this expansion of religious rights versus some of this insurance, and what you think of granting certain religious groups exemptions from having to pay into some of these programs.
Well, I don't want to draw a distinction between what I have personal views on and what I have thought about a lot. But I can tell you what my personal views are. I think that some of the notion of a freedom of religion that's appealed to and practice of religion is not justifiable. That if you look at the, and on this count I'll bow to the originalists. There was supposed to be a separation of church and state in this country. And that I don't think is being done by allowing for support for healthcare to go to support a lot of the religious views that some individuals have and use in a discriminatory fashion. So that's my personal view.
All right, so that concludes our program for today. Of course, we have lunch, so we want you to stay for that. I want to thank you. I want to say a thank you to our presenters, to our Bishop Lecturer, Dr. Norman Daniels, and to the Bishop family for making this endowed lecture possible, and also to the staff of our center for all of the work they have done today organizing this event.